Okay, I think we'll get started. Welcome, everybody. Before I have the pleasure of introducing tonight's speaker, somebody's yelling at me. Is there something? Can you not hear? Or? Oh, okay. Before I have the pleasure of introducing tonight's speaker, I want to first thank Maury Strauss, who's endowed this lecture series, for his generous support. And also, I want to give a little shout out and ad for some of the upcoming talks. This will be the last presentation in this series for 2019. And we'll reassemble after the holidays in 2020. The next presentation will be on January 23rd by Chris Austin, be talking about catalyzing translational innovation. Chris is the director at the National Institutes of Health of their National Center for Advancing Translational Research and Science, heads what's known as the CTSA programs around the country, of which we're one. And then in February, we'll be having a visit from Adam Ghazali, coming from UC San Francisco, talking about the promise of brain technology. Into March, we'll be having a talk on engineering reproduction, bench to bedside in babies, from Teresa Woodruff from Northwestern. And in April, Christine Stabell, a professor of global health from Denmark, will be talking about vaccine training of immune system. And then in April, Nobel laureate Michael Young will be here from Rockefeller talking about genes regulating sleep and circadian rhythm. So there's a lot of good stuff coming up. If you don't remember all that, check our website and make sure to come back. Okay, without further ado, it's a great pleasure to welcome and introduce tonight's speaker, Dr. John Halamka. Excuse me, Dr. Halamka is the Executive Director of the Health Technology Exploration Center for Beth Israel Lahey Health and chair of the New England Healthcare Exchange Network that is very well known for many contributions. Although as of today or tomorrow or a Sunday, he'll be becoming the president, or is about to become the president of Mayo Clinic Platform, a major new exciting undertaking. I've heard a little bit about it. It'll have Mayo Clinic, I think, very much in the leadership of areas of digital health and technology and taking on some of the grand challenges. So it'll be an exciting opportunity for him. Dr. Halamka did his undergraduate work at Stanford, had 2 undergraduate degrees in policy and microbiology. He entered the MSTP program at UCSF, where he received his medical degree. He also went on to get a master's degree in medical informatics at Harvard School of Public Health and in clinical effectiveness. Back when, it wasn't that long ago, but I didn't know they had medical informatics programs back then. It had to be one of the early programs. So, first one, there you go. He did his residency in emergency medicine at Harbor UCLA Medical Center, a fellowship in informatics at Beth Israel Deaconess. He's been a faculty member at Harvard Medical School, starting as an instructor, rising up to endowed professorship in emergency medicine, and also served as CEO of various labs and companies. He's chaired the New England Healthcare Exchange Network, as I mentioned, and chaired and co-chaired the U.S. National Health Information Technology Panel for both the Bush and the Obama administrations. He's an editor of leading journals, the Journal of American Medical Informatics Association, and serves as editor-in-chief for Blockchain in Healthcare Today and Telemedicine Today. He's won a number of awards recognizing his contributions. His career, I think, is a fascinating one. Somebody who's come up through medicine and a leader, but also in engineering, and has always had a foot in the entrepreneurial side of things and connecting it back to healthcare. Just a couple of his innovations that some of you, I'm sure, know about. He's one of the first early web-based clinical information systems that he developed. Emergency department dashboard support workflow systems, a system for one of the first personal health records systems ever developed, and also the New England Health Electronic Data Exchange Network that connects payers and providers together, and also a system for e-prescribing data exchange for discharge summaries amongst providers and so forth. So even for those of you from the general community who aren't in health systems, I think you get a sense of the level of the contributions that Dr. Halamka has made to this rapidly evolving world that we're all immersed in of digital healthcare and connecting best practices to data and the delivery of healthcare. And as I think we might hear in a moment, he has another side of his life too. But please join me in welcoming Dr. John Halamka.
Thank you very much. I told him to do the short version, which is Farmer Doctor Winemaker. And so we can either talk about Obamacare or Llama-care, whatever you'd prefer. I show you this. These are real-time video feeds from Unity Farm Sanctuary in Sherborne, Massachusetts, where I run the largest animal sanctuary in New England. And why would this be relevant to healthcare? Well, this is a look at my animal hospital where I have a series of animals that are quite sick, where I'm doing real-time telemetry monitoring of their activity 24 hours a day. I can control lights, temperature, and locks on each stall from my phone. In effect, we have a distributed group of experts looking in on them regardless of their proximity to Massachusetts. Now, I'm doing this for a 28-year-old Sicilian donkey. Why aren't we doing it for your health care, right? You know, my daughter, who is 27 years old and lives in Fairfax, Virginia, said, you know, Dad, I just moved to Virginia. It's a wonderful spot, but, you know, we did Grubhub because, you know, we were hungry, pulled out my phone. Wanted a ride, I just did a Lyft. I got a new primary care doctor who said to fax my records. What's a fax machine? So it illustrates we're at this cusp where we've got these emerging technologies, but the innovations that we have are not evenly distributed to healthcare. So we were talking about earlier, I've been in 40 countries this year, traveled 400,000 miles, so I thought I would take you on a bit of a journey through the world, talk to you about what's emerging in digital healthcare, and maybe some of the lessons learned in sub-Saharan Africa and northern India can actually inspire the US to adopt some innovative technologies. So here, in fact, you can see I can just touch my computer here. I can scroll through all my animals in every location, even their infrared cameras, so I can see things at night. But yet, we don't do this on hospitals quite yet. But we will. Okay. So, introduce you to my family. So this is my wife, Kathy. She, like me, is 57 years old. And in December of 2011, she was diagnosed with stage 3A breast cancer that was estrogen positive, progesterone positive, and HER2 negative. So she had a very simple question for me, which I imagine many of you work in healthcare or engineering. It shouldn't be hard to answer this question. So gee, you know, she's Korean. So of all 50-year-old Korean people with stage 3A breast cancer that's estrogen positive, progesterone positive, what was their cancer journey? Did they live? Did they die? Did they have side effects? How were they treated? Well, maybe you've solved this in the health system here, but I'll tell you, most hospitals and doctors' offices in this country can't answer a question like that. How do patients like me go through a care journey? So as the CIO of Harvard and its hospitals, I had access to all the data of the Mass General, the Brigham, the Dana-Farber, the Beth Israel. So I was able to go and mine 10,000 patients, Asian, not Korean, didn't have quite that many records, but 10,000 Asian women around age 50 with that diagnosis and those biomarkers. And what did we discover? Well, a lot of the women were treated with a drug called Taxol. And although Taxol cured their cancer, it left them with numbness of hands and feet, destroyed a lot of nerves, so they got neuropathy. Well, Kathy is an artist and has, for the last, since she was about 10 years old, done finely detailed oil painting and acrylics. So imagine her outcome of her cancer journey was total cure and total inability to create for the rest of her life. That would not be a good outcome. So her care preference was, I want health, but I also want function. So using the data of past patients, we did a clinical trial of 1. We divided her Taxol dose in half. And we agreed with her oncology team that if things didn't go so well, we of course could bring back the full dosing. But she got Cytoxan, Adriamycin, and Taxol at half strength and achieved total cure and is now in remission 7 years later with total function of her hands and feet. So yay. And that, by the way, is Palmer. He's a Royal Palm turkey. I'm told they taste really awful, which is a good thing if you're a turkey. And this is my daughter, Laura, and she is, as I said, 26 going on 27. And as I was getting at, her expectation of our healthcare system is that she shouldn't have to drive to some brick and mortar location to get the care she needs. She should have online guidance to what her signs and symptoms might be, and then appropriate escalation of care at the right cost in the right setting. So how many clinicians, I know we have some chairs of surgery and OBGYN here, but clinicians here? Okay, because I need to test somebody. Now, is that internal medicine guy here? Okay, here you go. Here's your test.
I'm also the chair, so
Okay.
you may have to decrease your expectations.
Don't worry, don't worry. I promise to make this so obvious, no problem. Okay. So my daughter, on a Sunday night at 7, of course, calls and says, "Dad, I have polyuria, polydipsia, and polyphagia." That's not actually what she said, but you get it. When a young adult has new onset diabetes, they drink too much water, they eat too much food, and they pee too much. And she said, "I feel like crap. I'm really feeling, I'm just so tired." And so, of course, in a young woman in her early 20s, when those are the signs and symptoms, there are a couple of things you could potentially worry about. Could this be onset of diabetes? It could be. Could it be pregnancy? It could be. It could be the flu. It could be lots of things. So what are you going to do Sunday night at 7? Are you going to take this person to an ER? God, I hope not. Right? I'm an emergency physician. And I don't know, are things here like they are in Boston? Like if you took a 21-year-old person to an ER with a chief complaint of "I feel weak and dizzy," about 14 hours later they might be seen, right? Yes. So at Beth Israel Deaconess, what we decided to do as part of our accountable care organization is open up an after-hours urgent care staffed with emergency physicians, and you make the appointment on your phone. So I said, Laura, go ahead and pull out your phone. Okay, it's now 7 o'clock. Take a look. Can you go in at 7:30? Yeah, bang, bang. 7:30 appointment. She walks in. They do a urine pregnancy test. They do a set of electrolytes. It's a nothing. Basically, everything comes back negative. And in typical emergency medicine fashion, we sort of rule out the critical issues and diagnoses. Do we know what virus she had? We don't. But go home, take some Tylenol, rest, get some fluids. It's not bad stuff. So I tell you this because this is her expectation. You should be able to pull out your phone based on putting in some signs and symptoms, be able to be routed to the place where they'll do the minimum necessary at low cost, and then go back to your life on your way. Well, let me give you another example that is me. So I have a very boring medical history. I have glaucoma. I inherited it from my father. You can't choose your parents. I happen to have an SVT. It doesn't really bother me. My heart rate sometimes goes from 55 to 170, but it's self-limited. It's all okay. Otherwise, pretty much nothing else. So a month ago, I was in Salt Lake City. I was lecturing with a group at Intermountain. I had flown in, I think, from Amsterdam or some such place. I had no sleep. I was really quite fatigued. I was quite dehydrated. Now, have you ever gone drinking with Mormons? Yeah. So it turns out it doesn't work really well. And I thought we went to a restaurant after my talk. Finally, we would get some beverages. No. And so we had this very large meal, again, even more dehydrated than I was in the past. I stood up and fell to the ground unconscious. Now, this has never happened to me before, and of course, everybody from Intermountain is looking at me like, did he have a heart attack, a stroke? Is this guy, who's our speaker, going to die? But what happened? So it turns out I'm wearing an engineering sample of a lead 1 ECG monitor that continuously sends my lead 1 ECG to my phone. This, by the way, it's an FDA clearance now. It will cost $70. It also monitors sleep patterns and movement and a few other things. So 5 seconds after I went to the ground, I'm back up. It's all okay. And so again, from an internal medicine, do we have a neurologist here? Okay, so I was not post-ictal, meaning I wasn't confused, I wasn't incontinent, this was not a seizure, there was no chest pain or anything of that nature, so this is like probably something benign. So we look at my phone, and I have this full tracing of what my heart did during this whole episode, and it turned out that as a physician at Harvard, I was able to text my lead 1 ECG to the head of electrophysiology at Harvard in real time, just like any of you would, of course. And he said, oh, look at that. Your heart rate was 55, 55, 55, 40, 30, 20, down. And then you came right back up. This is a classic vasovagal fainting episode that happens because you were dehydrated and tired and had a huge meal. It's okay. Go back to your hotel room, have a liter or two of water, you'll be fine. So I tell you that example because in the United States, where we have a lot of care, there's no question about that, probably the normal practice would have been, take me to an ER for a rule-out MI. I would have been in an ER spending $20,000 all night getting all kinds of studies, when in fact, all I needed was a liter of Aquafina. And shouldn't you, in the future, as you are wearing these kinds of devices, have access to those folks who can interpret them and give you the guidance for the right care? Now, if you need to go to the ER, go to the ER. But if it's a simple faint, then you just go back to your hotel room. So that's, you hope, the direction we're going to head in. And what am I seeing around the world in this regard? So this is the Western Wall in Jerusalem. And I was there recently keynoting a big data conference and met with lots of startup companies. Now, if folks spend time in Israel, you may know it is the startup and innovation nation. Kind of a remarkable place. 8 million people having the economic impact of 80 million people. And let me give you 3 startup companies. And don't worry, I have no stock, no financial interest, there's no conflict here. So first one, run by a 35-year-old wonderful physician, machine learning expert. Name of the company is Diagnostic Robotics. And what does it do? Well, you don't have any traffic here, so this is maybe a bad example, but do you ever use an app called Waze? Right? Well, what does it do? It crowdsources the traffic around you, and based on the traffic around you, decides what your path forward might be. Well, this physician in Israel is building Waze for healthcare. And the idea is everybody in your neighborhood is running an app, and when they have signs and symptoms, they type in their signs and symptoms, and so we know your location, the time of year, what's happening to your neighbors. And so again, I don't know the weather here in Roanoke so well, but what would be the likelihood of getting the flu in June? Probably not so high. Or a mosquito-borne illness in December? Probably not so high. So her notion is if you can crowdsource the data about people around you, understanding epidemics of flu and the way it spreads, or other things that might be environmental. Maybe there's lead in the water, or who knows. You're able, as a new person comes onto the system with signs and symptoms, to direct them where others have had a successful healthcare experience. And she combines this with millions of patient records of the past to understand what certain signs and symptoms might represent. So that if you have a headache, I mean, could it be a subarachnoid hemorrhage? Or it could. It could be a tension headache. It could be that it's too hot outside. I mean, there's lots of things. And so here's why it's so good for physicians. You're going to love this. So you, the patient, put in all your signs and symptoms and history. It figures out what specialist you're likely to get benefit from. It writes the note and inserts it into Epic. And so by the time you get to the office, the medical record is already done. And so all you have to do is put your hands on the patient, look at all the data that they provided, and it also provides a set of probabilities, right? It's not doing diagnosis or treatment, but it's saying, for patients like this, these are the diseases you might want to consider and the experience we've seen in this geography at this time of year. So in effect, it's not replacing a doctor. It's just making your life a bit easier. And again, I have only been here for one day, but is the electronic health record your favorite tool in the whole world? So if there can be something that reduces your burden as well as helps the patient, I mean, what a wonderful thing. Well, another company called Clue, C-L-E-W. Again, maybe engineers here have solved this, but their idea is hospitals don't have air traffic control towers. And what do I mean by that? So who's a hospital administrator? Do we have any administrative folk here? Okay. So the question is, how many people are in your ER right now? What's the average waiting time? How's the ICU? How's the PD ICU? When are people going home, right? it may not be so easy to answer all of these questions in real time, but if you're running an airport, isn't it kind of important to know when the planes are coming and going, that they don't crash into each other, and that you have enough gates available for the planes when they land? And so their notion, and they're doing this in Rambam and Sheba and Ikilov, is to build literally air traffic control towers for the hospital to ensure patient throughput is timely and accurate, but also to ask questions like, is there a patient decompensating? Right? Because maybe you've developed an artificial intelligence algorithm that says when people start having certain kinds of patterns, their blood pressure is lower than it was, or their heart rate's a little irregular, that maybe a few hours from now something bad will happen. So you'll move them to a different site of care before something bad happens. We've done a little bit of work at Beth Israel Deaconess on this. We call it the Triggers program. We actually looked at every bad thing that happened at the hospital in a year and asked, could you find patterns? Could you predict what might go bad and then prevent it before it happens? And it actually reduced our unintended morbidity in ward beds by about 50%. I mean, you can do models like that. So I thought, pretty ingenious. Well, last one, and where's my telemedicine expert? Red jacket, there she is. You'll love this one. This one's for you. Anybody have young children at home? Okay, young children at home. Okay, your child has just called you and said, I have a fever. What is that going to do to your workday? Yeah, it means, okay, got to get to the pediatrician, got to sit in a waiting room with all these other kids coughing on my child. And again, well, you don't have traffic here, but if you were in Boston, going 20 miles could take 3 hours, right? It's bad. So what this company in Israel did, called TytoCare, is they said, for parents, let me give you a little digital kit. And the human factors design on this is amazing. It's augmented reality, so that you, the parent with no medical training, can do an ear exam, an eye exam, a throat exam, and even heart auscultation, because it says, no, go more to the left, a little more to the right, up, down. And then it takes a 4K HDR, high-resolution picture of the tympanic membrane or the tonsils or whatever the issue is, and sends it to a board-certified pediatrician. And 5 minutes later, you have a diagnosis. Is this an ear infection or no? Oh, it's an ear infection. Look at the tympanic membrane about to burst. Here's an amoxicillin prescription, e-prescribed to the pharmacy next to your house. So end to end, the whole process took 5 or 10 minutes, and you never had to leave your kitchen. And every parent I tell about this says, send me one. This idea that we're going to be getting more care remotely, more telemedicine and telehealth for the not acute. Obviously, if this is something that's very acute, if it's a heart attack or a stroke, no. But I mean, for this kind of thing, it works great. So you've got to watch Israel for this. These products are coming into the US marketplace pretty soon. Okay. We were talking earlier, you've been to China a fair amount. So this is Washan Hospital at 7:30 in the morning on a Monday in Shanghai. Now, do you think it's a mass casualty disaster or an epidemic? It's Monday. And this is what it looks like every Monday. This happens to be the dermatology clinic on a Monday. Okay, for my administrator friend, so how many ambulatory patient visits would you have in your hospital, I don't know, in a given day? Any idea? Okay, so at Washan Hospital, they have 20,000 derm visits a day. Why? In China, there is no primary care. So every patient just decides where to go and what to, you know, oh, I had a headache. How about a neurosurgeon? Sounds good. So here, I'll take somebody in the front row. So you see this little brown spot? There's like this brown spot there. It's like, well, okay, I can tell you a few things. It's flat, doesn't bleed, singular color. It's nothing. But if you woke up in China and you said, I got a brown spot, I better go to the academic medical center where the famous doctors can look at my spot. And they line up. And this is what the waiting room looks like every single day. So China has a problem that many countries have, and that is we are all aging. As societies, if you look at China, Japan, Sweden, Finland, Germany, Italy, where's my friend from Germany? I know he's here. There he is. You know, so we're all aging. And the problem is that we don't have enough doctors to provide the services that are necessary to the aging population, nor do we have enough money to pay for it over time. So we have to do something different. So what is China thinking about? What if for every dermatological lesion you took a high-resolution photograph and built machine learning models that could therefore enable a patient to just pull out their phone, take a picture of the lesion, and say, oh, we just compared this to 10 million other lesions. It's probably nothing. Now, if you want to see a dermatologist, in 2 weeks, we'll schedule an appointment for you over here. You don't need to stand with 20,000 other people today. So their recognition is the only way we're going to get through the next 50 years of aging societies is to start using augmentation of our physicians. So our right physicians are seeing the right patient at the right time, and many of these problems can be triaged away without requiring immediate physician consultation. I know people are going to ask me, oh, does that mean AI is going to replace doctors? Well, how about this? If AI can replace your doctor, AI should replace your doctor. Because why did I become a physician? It's because of empathy and listening and respect and care navigation for the family. These are not things that machines do well. Would I love augmentation that helped me understand what diagnoses I should think about? Of course, that would be great. And let me give you an example of what I mean by augmentation. This is not a HIPAA violation, don't worry. For the clinicians in the room, do you ever get called by distant relatives or friends of a friend of a friend who said, I got this medical thing. Can you help me navigate the US healthcare system? Right? I get this every day. So I get the following call. This is a real call. Friend of a friend of a friend says, hey, my daughter was just arrested running naked through a Walmart parking lot in Bakersfield, California at 3 in the morning. Can you call the ED physician and figure out what's going on? So, of course, sigh, I can do that. Called the ED guy. He said, you know, we ran a tox screen, and what did we find? Cannabis. Yes. Demon marijuana. And therefore, it completely explains why a 24-year-old woman would run naked through a parking lot at 3 in the morning. Now, if we had an AI system that looked at every record of every person acting goofy at 3 in the morning, I can guarantee you cannabis would not be anywhere near the top of the list. But he discharged her and said, I have no other workup needed because we found cannabis. Then her parents were quite unhappy. We arranged to fly her to Boston. And this is the weirdest medical thing I've ever done. I had to get on the phone with the pilot of the JetBlue flight and offer my medical license to say, she won't disrupt your flight, don't worry. It's like, thank God she weighed 112 pounds, her brother weighed 250, and he was sitting next to her. All right, so she gets to Logan. We take her to Beth Israel Deaconess. Okay, and we got my internal medicine guy here again. So we did a lumbar puncture. She had 9,000 white cells in her CSF with 5 RBCs. She had the worst case of meningitis anyone had ever seen. Now, does a 24-year-old with meningitis get goofy? You know, certainly possible. And so after a week of antibiotics and recovery, I say, well, what about this marijuana thing? And what she said is, you know, I had 2 days of the lights were really burning my eyes and I had this horrible headache. So I asked my roommate, do you have anything for that? And they just happened to have some cannabis sitting around. And so the marijuana had nothing to do with her altered mental status. And this was a near tragedy that if an augmentation system told the physician, it's really unlikely to be a cannabis problem. Do something else before you send her home. Certainly, tragedy would have been averted. We were just lucky. So you'll see more and more of that, and I'll give you some more AI examples in a second. Okay, how many folks have spent time in India? Okay, so this is northern India in Bihar state in a town called Patna, which is on the Ganges near Nepal. The per capita income in this city is $1 a day. And there is no sewage facility of any kind, but there's 4G bandwidth and Android phones in every household. So ask yourself this question: if you want to deliver high quality medical care, even in a rural area, and everyone has an Android phone with 4G connectivity, you actually have some interesting options. So here's the case. Okay, let's see, I picked on my internal medicine guy too much. Yeah, pulmonologist, infectious disease person. Okay. Oh God, okay. So, 25-year-old woman. 8 months ago, she gave birth to a wonderful baby boy who's totally healthy and has had intractable abdominal pain since then. She's been to doctor after doctor, hospital after hospital, had every antibiotic imaginable, Godzilla-cillin, no relief. And so she's coming to this clinic that I'm running in the streets of Patna, which was a Gates Foundation funded activity where we had a few other interesting diagnostics in our armamentarium. We had a $10 gene expression test called Gene Expert, which I ran on her. And I discovered that it was positive for tuberculosis. Now you see I'm looking at her chest x-ray, looking for, is there something in the apex? She had abdominal tuberculosis. Now again, you're an ID guy, so maybe sometime in your life you've seen this. I have never seen abdominal tuberculosis. So here we are with a cell phone in a street with a $10 test diagnosing a patient who had failed 8 months of hospital therapies at basically no cost. So what is the Gates Foundation doing? And I think it's a great idea. They're funding 45,000 community health workers throughout India. Remember, 1.3 billion people, about 600,000 docs. And each community health worker will be given a phone, but also some Internet of Things devices like a blood pressure cuff, a glucometer, a spirometer, some things that connect to the phone so you can do some basic telemetry gathering from the patient, as well as run selected diagnostic tests in a very simple clinic. And for those folks who've been to India, this clinic, if you look at the walls behind me, they're actually covered with cow manure as an insulation. It keeps the place pretty warm. But I mean, this is the kind of healthcare delivery environment you're dealing with. Not a lot of resource, not a lot of docs, but community health workers with phones can really make a difference. So the end result for an ID perspective, we gave her a fixed dose combination of medications for TB. She took them totally fine, and she had lost her life savings, her cow and her land, by getting inefficient, ineffective medical care. So we ran a GoFundMe and bought her house and her cow back. So there you go. End result was good, process was bad. And I tell you that because, are there rural spots in Virginia? Yeah. Are you delivering high quality specialist care to those rural folks? As long as they have a cell phone, you could. Okay, a bit of a word of warning here. Is anyone from Australia? Okay, see, you always have to check. So Australia decided it would be very patient-centric to give every single patient their lifetime medical record, so you could just go to a government website and download your medical record. That does sound good, doesn't it? Maybe. They chose a very advanced technological standard called PDF. So what does that mean? The doctors took their digital data, printed it, and faxed it to the government, who then rendered it as literally this PDF that you could sort of read. Can you do machine learning on a PDF? No. Can you do analytics? Can you do predictions of badness? Nothing. It's a totally useless system that they built for millions and millions of dollars. So this is the word of warning, which is that if we decide as a country or a region or, hey, even a city to do something with healthcare data exchange, don't put it in digital paper. Create mechanisms so the data can be reused for many good purposes. Quality measurement, identification of epidemics, the machine learning kinds of things we're talking about. And the good news is Australia has decided it made a mistake, and will change. In the United States, we do have some unique challenges. There are 330 million people here. As you might all agree with, as a society in the United States for a moment, we have a lot of discord and polarization. And so agreeing that we're all going to do something together is kind of hard. If you look at Norway or Finland or Denmark, they'll just make decisions for their 5 million people and everyone says, great, let's go forward with that. So in Finland, your medical record is the property of society. Their notion is society is keeping you healthy, so of course you should contribute all your experience to the help of society over time. So I just, again, not to get political or anything, but imagine that we all agree in the United States we're going to create a giant database in the basement of the White House run by Jared. That may not be so easy to sell. I tell you all that because when I give you examples of some of these other countries, things actually are harder here. And so I don't probably believe we're going to end up with a giant centralized database of all our healthcare. What I hope is that, for example, your healthcare system will do a lot of these kinds of things. And then that data, that learning, will be shared broadly. And this is a notion of more federated learning without centralizing the data or requiring the government to be the organizing principle. So a couple of thoughts. So what are we going to see in the short term? We'll see more and more devices in the home. As I said, this thing that I'm wearing, or as you saw, the animal care that I can do remotely. I have colleagues in China that are working to put medical sensors in appliances, so this just becomes part of the fabric of your life. We're going to see more and more machine learning being used to augment not only doctor decision making, but workflow. So let me give you an example for the hospital administrator. Do you know, based on a patient who comes to the ED, who should go to a ward bed in an ICU? Well, you sort of guess. The doctors make a decision. But what if we had millions and millions of examples? We could say, a million people like this went to an ICU, you probably should do that. It's just going to help move the patients to their right setting of care. Or figure out who's going to show up to their appointment and not, based on a model of who has done it in the past, and schedule your outpatient clinics better. So we'll see more of that. We're going to see more uses of the cloud. Now, for my friend in Germany, because I was telling him that I was just meeting with the health minister of Germany, in Europe, they don't like the cloud so much because they worry a bit about privacy. And is the cloud safe? And if the cloud sends data across the German border, is that okay or not okay? So there are a lot of policy questions that we'll have to decide together as to where data is stored, how it's used, not only legally, but ethically. And you've probably seen some controversy in the news about where your healthcare data might flow and who's using it. One of the things that will force us all to move is the idea of pay for quality and pay for outcomes. So in Virginia, you're starting to see ACOs and this notion of I won't pay for heads and beds, but I will be paying for outcomes and quality. Because if you do that, it's actually cheaper to keep people healthy in their homes than to wait until they're sick. Buy them bathroom scales and monitor your congestive heart failure patients for their daily weights. And if they're having a decompensation, send a nurse to their home. We'll see many more of these models. But there are still challenges. So I was talking here to Sarah about an interesting problem I have with my Internet of Things data. So it turns out, as I was showing her, I don't sleep very much, about 4 hours a night for the last 40 years. But look, you can see here, it's like I'm sleeping 10 hours a night now. Why? Because we adopted a pit bull from Louisiana as a foster who sleeps on my side of the bed. And so all the data about sleep is not correct. And here, I'll even show you something else. You'll see, look at all this snoring you're seeing. I don't snore, but the dog does. And so we're going to have this problem as we get all these new sources of data from the home or from the wearables of figuring out whose is it. And even think about this complexity. We were talking about this human factor. My wife and I have been together for 40 years. what the company says is, oh, we can detect snoring of each partner because we'll synchronize the snoring pickup in your bed sensor with your respiratory rate. Well, do you know what happens when you sleep with someone for 40 years? Turns out you develop the identical respiratory rate. It just happens. And so it doesn't work anymore. So these are going to be fascinating data and human factor problems to solve with trust and interpretation. We're also going to be overwhelmed. I mean, again, let's talk about your electronic health record. Again, I'm in Virginia here, so you may not have this problem, but do people ever cut and paste? Do you ever get lots of data from all kinds of outside physicians and it's just either unreadable or unusable or inaccurate, right? So we just have all this noise. And trying to separate signal from noise will require us to have new tools because clinicians are feeling overwhelmed. Now, we were talking about this human factor issue too, which is my heart rate is 50 to 55, but I have a person who works on my farm with a heart rate of 100. So if you were to say my heart rate is 100, that would be bad. For this other person, no problem. If you were to say her heart rate was 55, that would be bad, but not for me. So even to understand for each of us what our normal range of variation should be, that is a hard problem. So anyone with an Apple Watch Series 5, if you start sending your ECGs to him every 5 minutes, he's going to go crazy, right? You got to figure out. And then finally, security and privacy. Okay, I know you've been to Japan some, but not a lot. But anybody spend a lot of time in Japan? Okay, so how many hospitals in Japan are connected to the internet? None. Why? Because they believe the internet is a swamp of malfeasance and thieves. Now, it probably is, but their sense of risk is that they won't even connect the hospital to the internet. It's that bad. I will tell you, I have had 3 publicly reportable privacy violations in the Harvard hospitals in the last decade, none of which I could control. They went something like this. Dr. Famous, not his real name, bought a laptop at the nearby Apple store. By the way, he was a surgeon. We got to talk to him. And so let me tell you about this. He had 119,000 emails in his inbox. I mean, I think that's pathological. I don't know what you think. But anyway, so he downloads 119,000 emails onto this MacBook, goes to a meeting, comes back, the MacBook is gone. He calls me up and says, but don't worry, I used a password. Now, I tried to explain to him the difference between encryption and a password. He said, oh, I didn't do that. So what did that mean? I had to hire 30 people to read 119,000 surgical emails and classify in a rubric. If you said, Mr. Smith has appendicitis, not really a privacy breach because there are a lot of Smiths. But if you said, the famous executive director of an institute in Roanoke, Virginia had appendicitis, well, that could probably be a privacy violation. We'd figure out who you were. We had 4,000 patients that were defined. You could figure out from this email set. Therefore, I had to go to the Office of Civil Rights. I had to go to the Attorney General. I had to go to the DPH and say, I, as the Chief Information Officer, am responsible for the potential breach of 4,000 patients' privacy. I'm so sorry. And then, of course, there was a legal settlement that was involved. The laptop cost a little over $1 million. And I'm not sure how I could have prevented that other than take away his Visa card, right? So, or another one, we had a CT scanner where if you buy a CT scanner today, it comes with an operating system, this is true, called Windows XP. Right? And why haven't they updated it since 1997? Because they said, oh, it's FDA certified. We can't update it. Yeah, well, it's not exactly true. The technician who was servicing this particular CT scanner needed to add an update. So he brought a 100-foot cable and connected the CT scanner to the public internet. And then went to lunch. 30 minutes later, 3,000 images were sent to China. We have no idea why or where, but once again, I had to go to the Office of Civil Rights, the Attorney General, et cetera, et cetera. The good news is, Office of Civil Rights decided against the company, not the hospital. But they did warn us, if this guy ever shows up again, take away his cable. So I tell you these examples because privacy and security is hard. And very often it's human fallibility that leads to a privacy breach. People clicking on that link they shouldn't click on. Or people doing things like, oh, here's maybe the dumbest one I've ever had. I was in the Moscow airport last week, and you know, this wonderful woman gave me a thumb drive for free. My laptop's really slow. Could you help? It's like, oh, God. So be aware that I needed to multiply my security spend at Harvard by a factor of 5 over the last couple of years to deal with the threats that we have on the internet, malware, clickables, all this other stuff, to in effect prevent people from using USB drives from Moscow, or clicking on links that aren't real, or doing stupid things like buying laptops and plugging them into the network. It's all now protected against. It's a Cold War. And we battle our security and privacy issues every day, so think of it as a project and not just a single event, and that project will never be done. So there you go, and I did want to leave some time for questions, but just to sum up, I think the future of our digital health economy, despite what you might read in the newspaper of late of a couple of startups not doing so well, is very bright. You're going to see a whole lot of new apps and services in the cloud and on your phone, devices in your home. And I think the innovation is going to actually come from places like this. It's not going to come from government. Government will be a convener and will make good policy, but it really is up to the innovators in a place like Roanoke. And as we were talking about, this seems to have all the right ingredients. It has the people and the resources and an urgency to change. So I leave you with the notion that it's all up to you. But let me open up to your questions and thoughts. And so you see, Bill Gates is actually pretty short.
Okay, floor's open. Questions? Please stand up so we can all hear you when you ask your question. Go ahead.
Hi. We do have an ACO here. We rely a lot on predictive analytics for deciding when to intervene on the population level. There was an article in JAMA by Perrick about the recapitulation, artificial intelligence, and the risk of recapitulation of bias through that. Is that something that worries you a lot, or do you think we can construct models the right way so we don't fall prey to that?
Sure. So let me expand upon what he said, and I'll give you a couple of examples. So when you train an AI system, you really need to curate the data and understand the source data, because otherwise it's garbage in, garbage out. Okay, see, I got to keep picking on doctors here. So when meaningful use happened, I bet your behavior changed. You had to do different things with your electronic health record. So we used machine learning models on all of our data for our ACO. And you know what it said? It said in 2009, people got much sicker. Like, no, it was just doctors started typing more, right? And so you have to be totally, really quite careful about things like data quality is poor, the EHR versions may change over time, and as he just said, there may be certain biases built into the system based on race, ethnicity, income, for which when you do a model, it actually isn't giving you the best recommendation for the person in front of you. And a quick comment on the digital divide, because it's relevant to data. There's a large search company in Mountain View, California. I won't mention which one. And they sent a number of engineers to our Medicaid clinic. This is the folks who are low income, under-resourced, may not speak English as a primary language. And they walked up to this homeless gentleman and they said, "So, what's your favorite wearable?" And he said, "Socks." And what it just sort of illustrates is that as you look at different levels of education and technological comfort, the data that you're going to gather may vary. And so we are extremely careful when we do AI models to make sure the questions we're asking are fit for purpose with the data that we have, and the data is cleaned first.
Yes, go to stand up.
Thank you for recognizing our potential as innovators, but we're also a training program, so I'm curious about what sort of professional development you would like to see in the next generation of clinicians and translational researchers that you think would best prepare them to come into their professional lives ready for the digital future.
Well, excellent question. Now let's see. Were you a medical school dean in your past? Okay, there's got to be somebody who's a dean or a decision maker about the curriculum in here. So I went to medical school in 1984, and we had to memorize something called the Krebs cycle. Have I ever used the Krebs cycle in my life? No. But yet I had an examination for which my future depended upon recapitulating every element in the Krebs cycle accurately. I mean, this is stupid, right? What you need to do is teach our next generation of leaders not the Krebs cycle, but the data life cycle, right? How do we gather data, cleanse it for AI? What are the techniques for analytics we can use? And let me tell you something slightly depressing, but again, maybe you've solved this. You, in your institute, need to hire a person who's 23 years old, who's fresh out of engineering school with 1 year of machine learning experience. What will Google pay that person as a starting salary?
A lot more than we can.
$300,000. Right? Okay, everybody's moving to Mountain View. The point being is that we need people with these experiences in next generation analytics and machine learning and Internet of Things and all the rest. But unfortunately, we have to compete with Google and Amazon and Apple and Facebook. So sometimes you collaborate with those companies and get their talent, but it would be wonderful if every single graduate student had at least the basics of TensorFlow and R and SPSS, these other tools under their belt. No Krebs cycle.
If I may, just to follow up on that question, if I could take one question. So you've talked a lot about technology disruptors, but not so much on the economic side. And what I mean when I say economics, I mean the healthcare system and delivery of healthcare and the vested interests of the existing infrastructure. And so if these things all play out the way we think they are and you describe, you're going to turn the health system on its head economically. What are the forces that'll allow that to happen or keep it from happening, as far as you're concerned?
I got into a little bit of the demographic pressures, but I was in Shanghai lecturing to 100 hospital CEOs, and I said, in 10 years, your measure of success should be your hospitals are empty. And they went, oh my God, that's so horrible. We want sick people. Because we're paid for sickness. Right? And so what I told them is, what if you took your bricks and mortar and you built telemedicine centers for virtualists that were able to keep people healthy in their homes at a fraction of the cost, but the government decided you'd be paid for that as a service rather than heads and beds. And then what they said is it would require massive changes in the way reimbursement is done for us to be motivated to do that. So what are we seeing in the US? There is now a billing code for Medicare. See if you can figure out how to use it, though. For telemedicine and for remote monitoring. They're there. It's just they're very nascent. So we're starting down a road. We're going to start reimbursing some of these care at a distance services. And this work that I'll be doing at the Mayo Clinic starting Sunday is asking the question, how do we deliver home hospital services, advanced diagnostic monitoring, and the decision support in AI to scale as a business, recognizing that 10 years from now, hospitals will need to be data businesses as well as empathetic care locations. So, yeah, a lot of market forces for sure.
Yeah. Sorry, I didn't mean to. I know you.
Yeah, I think there was a gentleman over there.
Stand up.
You have Bill Gates on the screen there, so it brought to my mind, as academic centers, are we going to be competing with Buffett and Gates and Bezos in their medical project that they announced a couple years ago, and maybe you could address where they're at,
Sure.
if they're at any place at this time?
Sure, so I'm happy to answer that question with everything that I know. So we'll take Google, Amazon, and Haven, which is, he's talking about the Amazon, Berkshire Hathaway, JP Morgan Chase collaboration. So Google does not want to compete with you. Google wants to be a tool provider to store your data, analyze your data, help you with machine learning algorithms, but they don't have internal healthcare expertise. So their hope is they can sell to every hospital and doctor's offices these tech-enabled services, which, interestingly enough, because I've done a lot of this, turn out to be lower cost than my doing it myself. So that's okay. I mean, and I've talked to all the Google people. They aren't going to get into the EHR business. They're going to get into data visualization and these kinds of things. Amazon, so similarly, they're going to do the supply chain. So the medications that I take, I say they're very, very boring, right? So I take latanoprost for my glaucoma. So what do I have to do? I have to get a pre-auth from the insurance company so that a CVS Caremark can ship me every month one small container. It's ridiculous, right? Shouldn't I be able to have a supply chain that gets me when I need the med, figuring out the way I use it without a lot of hassle? So that's why they bought PillPack. So they're going to get into things like delivering, just as you order things from Amazon, medical supplies, pharmacy goods, and that kind of thing. And they're doing some things for their own employees, this Amazon Care thing. Now Haven, what about that? So Haven, as a collaboration of Amazon, Berkshire Hathaway, and JP Morgan Chase, was created for one reason: to reduce the cost of healthcare to Amazon, JP Morgan, and Berkshire. That's really what they're doing. So a lot of their models are, how can we do insurance differently? Reducing a lot of the overhead that today, 25 cents or 35 cents of every dollar in the US is going to overhead or middlemen or these kinds of things. How do you start fixing that problem? So again, that company, Haven, not going to compete with you. So how about this? At Mayo, I'm now charged with doing this Google collaboration, and it's truly all about having tech do things that hospitals aren't that good at anyway without competing with them. So I think it'll be fine. Other questions?
Okay. Any other questions? If not, yes, go ahead.
yes,
Go ahead. Jump up, please, so we can all hear you.
Yes.
If I can.
Oops.
Thank you. Thank you for the great talk. I was just curious, so as you have a very good global view, in terms of other healthcare systems in the world, so what other healthcare system actually right now have the most advanced, machine learning and technological, applications that actually, demonstrate that these models are indeed what we need?
So she's asked the most brilliant question of the evening, also the most impossible to answer. So I'll give you just a couple of exemplars, but the problem is they don't, as we were talking about, don't play in the United States exactly, because we're just a different society. So Singapore, anybody been to Singapore? Okay, so you can't chew gum there, right? It's top-down command and control. How many medical records do they have for the entire country? 1. Right? So of course, every patient is in the same medical record system. So if you go to any doctor for any service, every doctor can perfectly see everything you've had. The machine learning is done on your whole life, and everything is done top-down command and control. That's great. To your point, the US is probably not going to get there.
So the key seems to be consolidation of the data.
Well, or figuring out ways in which we can leverage the data even if it's federated. But let me give you one other example. Scotland. Anybody spent time in Scotland? Okay. So in Scotland, PACS. This is an image management system. Do we have any radiologists here? Okay. How many PACS systems do they have in Scotland? 1. Any image can be viewed by any doctor anywhere in the country in any modality. And so when they do 3D reconstructions, when they do machine learning, it's on 1. Or, as I say, Finland, Denmark, Norway, Sweden, the data sharing there is at a societal level, and that's kind of agreed upon. So yeah, we can look at these other countries as doing great things, but maybe they just tell us in the US we have to do better at sharing our data, even if it's not all centralized in one place. Well, thanks, and of course, I'm very easy to reach.
Thank you. Thank you very much, John. Fantastic way to end the year with that talk. So please join me again in thanking Dr. Halamka.
Thank you.